If there's anything in medicine that I like, it's sleep. This is my favorite set of topics and my favorite aspect of medicine. So, forgive me if I'm like a kid in a candy store, because I love this stuff. And what you'll come to know as we go through is that sleep will be at least a question you should touch on with every patient encounter. Because as I'm going to show you, sleep and/or dysfunctions in the world of sleep can have wide-ranging effects. And so this is a, unfortunately it's Friday at 3 o'clock, but this is a great set of stuff here. So to understand sleep, we have to understand circadian physiology. And you all are probably never going to want to see me again because you're like, all these damn slides deal with neuroanatomy and neurophysiology and all that kind of stuff. But it's important to really understand. So let's talk about circadian physiology. I'm going to make it really, really simplified for you. So light activates the retina. Retina sends information to the suprachiasmatic nucleus. Suprachiasmatic nucleus has two main parts. One part is winding the 24-hour clock, and the other part is sending information to the pineal gland. What does pineal gland do for the most part? Secrete melatonin. Okay, so it's light outside or it's light in here. My retina is activated. It's sending information to suprachiasmatic nucleus to say it's light outside, so we're dealing with the 24-hour cycle, and I'm sending a direct connection to pineal to say no melatonin. Please don't secrete that right now. As it gets darker, less light is activating retina. Retina is sending less information to suprachiasmatic nucleus. Suprachiasmatic nucleus is saying, wind in the 24-hour side, and I'm now reducing my innervation on pineal. So pineal is allowed to secrete melatonin. Melatonin then feeds back on suprachiasmatic nucleus to say, keep winding the 24-hour clock. And melatonin acts as what I want you to think of as a dimmer switch. Melatonin is not an on-off switch in the brain. It is a dimmer. This is why you're going to have to really learn your medications if you choose to treat a patient's complaint of insomnia. And we'll talk about insomnia treatment of those kind of things. Because certain medications are on-off switches, and certain medications work through the melatonergic system as a dimmer. So the dimmer switch is a natural reduction in the activity portions of the brain so that we can allow the physiological process of sleep inertia to happen. Okay? And in the second lecture, because you're like, dang, 2 lectures on sleep? In the second lecture on sleep, we're going to talk about the orexin-hypocretin system. The reason there's a whole lecture there is because science is really moving in that direction, and you'll see why all of these neurochemicals and neuropathways are so important. But that's the main thing. So what type of light really activates the retina? All light, correct, but which type really winds this system? Blue wavelength. Blue wavelength light. What is the thing in this world that produces blue wavelength light? The sun. Yes, as we've gotten more advanced in technology, your computers, your iPods, your iPads, your whatever device you've got in your hand at night, your television sets are starting to produce a lux of light that is getting more and more similar to blue wavelength. So you're screwing your sleep up by using these things later and later into the evenings. And we'll talk about that as we go a little bit through circadian rhythm shifts. But basic circadian physiology. So there are multiple factors that are involved with sleep regulation. And so there are behavioral factors and there are endogenous homeostatic factors. And behavior can actually interfere with and or influence both homeostatic and endogenous sleep regulation. So homeostatic is basically, as you're awake longer, you are wanting to have a drive to sleep. So the endogenous side, though, deals with melatonin, and the most important thing that drives sleep, believe it or not, is on this slide. If you look at all of the sleep literature from eons ago, core body temperature will tell me a lot about your sleep patterns, your sleep cycle. And by manipulating core body temperature, we can actually manipulate sleep patterns. So you have a homeostatic drive and you have an endogenous drive for regulating your sleep. So as we mentioned, circadian phase is about 24 hours, 24.2 hours, and it's controlled by the suprachiasmatic nucleus. What controls that circadian phase is what we talked about: retina, suprachiasmatic nucleus, pineal feedback, and our friend, core body temperature. So how do we synchronize? We synchronize the suprachiasmatic nucleus through retina being activated by blue wavelength light. And by inappropriately activating the retina with blue wavelength light, we can shift our sleep phases. So you can interfere with your sleep onset and your wake time purely by using those devices that are in front of you. And that's very important in the age of technology when patients come in and talk to you about, I can't sleep. And so sleep hygiene and taking a good sleep history is very important in what are you doing that might be affecting your ability to achieve sleep, maintain sleep, and so forth. What should the bed be used for?
Sleeping.
Sleep. There's two other S's. There's three S's. The bed should be used for three S's. Sleep, sickness, sex. Okay? And that also means you shouldn't be using these in your bed, your phones in your bed, your TV in your bedroom, those kind of things, because we're inappropriately activating that system when we shouldn't be. So let's start with insomnia, because we got to go through insomnia, the apneas, the circadian rhythm disorders, restless leg, restless limb, periodic limb movements, those kind of things. So let's start with insomnia, because one of the most widely complained about issues that a patient will present to primary care with, or psychiatry with, or to me in sleep, or to me in pain, is I have insomnia. But insomnia is not just a simple definition of I can't get to sleep, or I can't stay asleep. And insomnia isn't just a result of or provoked by a single factor. Insomnia is one of the most multifactorial issues that you'll have to tear apart when you're dealing with patient interaction, because what? Just somebody that has poor sleep hygiene can come and complain of insomnia. Certain psychiatric conditions. We talked about the pain triangle last time, pain, mood, and sleep. If I deprive somebody of enough sleep, especially rapid eye movement sleep, I can induce psychotic behavior. So we know psychiatric disorders can impact sleep. We know that certain medical conditions can impact sleep. Obstructive sleep apnea. Heart failure can induce central sleep apnea. Certain medications that people are on will affect sleep. Beta blockers can make people sleepy. Other medications can affect sleep quality or sleep quantity. acute stressors in life. So these don't have to be necessarily chronic psychiatric disorders, but somebody can have an adjustment disorder or some other acute stress reaction that's going to affect their sleep. Or you preparing for an exam and feeling angst about that exam, or some other activity coming up in life can affect the way that you sleep. Circadian rhythms, advanced phase, delayed sleep phase, jet lag, shift work sleep disorder, all of those things can present as, I have insomnia, I can't sleep. And then you have other, what are considered, or what may be, in my opinion, misnamed as primary sleep disorders, but other sleep-related disorders such as restless limb syndrome, periodic limb movement disorder. And so what this highlights is that Miss Jones coming in telling you, I can't sleep, is not as easy as, well, let's try drug X for you to get to sleep. Because we've got to figure out where in this is Miss Jones, and then what can I do to try to impact the complaints that Miss Jones has. So insomnia can be classified in multiple different types, but we're going to talk through sleep onset, sleep maintenance, mixed early morning arousal with inability to get back to sleep. So sleep onset insomnia, these are people who have difficulty achieving onset of sleep, but once they are asleep, have the ability to maintain sleep for an appropriate period of time. Sleep maintenance insomnia are patients who present with complaints of, I can achieve onset of sleep, but I may wake multiple times throughout the night and may or may not have difficulty returning to sleep. What we could consider mixed insomnia are patients who have a combination of sleep onset and sleep maintenance related issues. And then early morning wakening with an inability to return to sleep is a hallmark of what?
Alcohol use.
Say it louder. Not old age. We're going to talk about how dementia affects this in older age.
Alcohol.
Nope. Mood disorders.
Depression?
Very common that depressed patients will complain of, I wake at about 3 a.m. and my brain starts kind of going and my mood is a little labile. They don't use that term. But they have, I wake in the early morning hours and I cannot get back to sleep. So patients that come to you complaining of early morning awakening with inability to return to sleep, you need to be evaluating for mood disorders. So sleep onset insomnia, this is basically an exclusionary thing. This is where you're going to evaluate to make sure there aren't behaviors patients are engaging in that are prohibiting them from going to sleep at a desired sleep time. So use of devices that are activating that retina and suprachiasmatic nucleus, exercise too close to bedtime, caffeine too close to bedtime, engaging in other activities in the bed to where the brain has learned that the bed is used for eating Cheetos and playing PlayStation instead of the three S's. So your sleep onset is really, your sleep onset insomnia patients are really a diagnosis of exclusion after you've gone through everything else. And I will tell you, don't treat sleep onset insomnia with drugs just because that's what patients want. Okay? The most effective treatment for sleep onset insomnia, and really sleep maintenance insomnia that's not due to a medical condition, is cognitive behavioral therapy. Study after study after study has shown cognitive behavioral therapy to be as or more effective than pharmacologic treatments for insomnia. The University of Wisconsin did a great study, it's been about 10 years ago now, and they looked at face-to-face, in-person cognitive behavioral therapy versus a program that they developed for online cognitive behavioral therapy. The problem with cognitive behavioral therapy is A, you have to have somebody that's well-trained to do it for insomnia, and B, it's expensive because it's multiple weeks. I will tell you, there is nobody in the state of Oklahoma that does cognitive behavioral therapy for insomnia worth 10 cents. The best, closest place is in Colorado Springs. There's a program there that is phenomenal. However, this state of Wisconsin study used an online program called cbtforinsomnia.com. You will want to write that down because it is great. It's like $39.95 for 6 weeks of cognitive behavioral therapy online. You have access to a psychologist and psychiatrist, and they have all of the modules built. For a patient who is motivated to really get down to the nitty-gritty of treating their insomnia, cognitive behavioral therapy has been proven to be the most effective long-term, and we now have online programs that have been proven. This online program has been proven to be statistically equal to in-person, face-to-face cognitive behavioral therapy. It's cbtforinsomnia.com.
Like the number four?
No, FOR. Sleep maintenance insomnia. So waking multiple times through the night. This could be somebody who has a mood or anxiety component, but more commonly, sleep maintenance insomnia is the result of a general medical condition. Most commonly, sleep maintenance insomnia patients suffer from apnea. And we'll talk through apnea in a few minutes. So I caution you again at treating sleep-related complaints just with pharmacology, because certain drugs that we use to treat sleep can suppress the respiratory drive. So during the daytime, you and I are under somewhat voluntary control of our respirations, correct? We can take a deep breath in and hold it for several seconds. We can breathe more rapidly. We can breathe shallow. We can breathe deep. But at nighttime, we are not under voluntary control of our respiratory status. What is the main generator of our respiratory status? What, in my world, what area of your brain stem?
The medulla.
Okay, so the reticular activating system, right? And the reticular activating system then is driving your respiratory system by monitoring chemoreceptors, correct? And we have a large number of chemoreceptors in two main areas as it deals with sleep and respiration. Where are they? Reticular activating system, and has to do with your cardiovascular system. The arch of the aorta. Okay? And these chemoreceptors are monitoring what? What are they looking at?
Oxygen content?
Wrong.
Pressure.
Carbon dioxide. Metabolism of carbon dioxide is what drives your respiratory status through this system. So chemoreceptors are monitoring carbon dioxide tension or metabolism, and in the arch of the aorta, and in the reticular activating system to be coordinating your respiratory efforts. That's going to be very important as we talk through apnea in a few minutes. Mixed insomnia patients, these are a little more difficult because you're going to have to tease out things like apnea with all of that other big sunshine thing that I showed just a few minutes ago in your early morning with the inability to wake back up. These are folks that you need to treat their mood disorder, and once you do that, the sleep cycle gets a little bit better. So insomnia treatments, as I mentioned, cognitive behavioral therapy. That is number one, ding, 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 that should be the answer. However, patients don't like that. The Western medical model is give pills. Patients are in tune to give me a pill and make it better. I don't want to put a lot of effort into anything. So, what else do we have available for those that want the easy routes? BZRAs, benzodiazepine receptor agonists. So we're going to activate the benzodiazepine receptor complex. These are, and I'll give you both trade and generic names. Ambien, which is Zolpidem, Z-O-L-P-I-D-E-M. Ambien comes in a short-acting and a long-acting form. Lunesta, which is Zopiclone, S-Zopiclone. Zopiclone's in Europe, S-Zopiclone's in the US. Sonata, which is Zaloplan, Z-A-L-E. Zaloplan. Sonata has a much shorter half-life than does Ambien or Lunesta. Of those three drugs that I've just mentioned, have you all talked through any of those yet? No? Okay, so I'm getting to steal Dr. Latassi's thunder a little bit.
Well, you set her up, so she'll
Okay.
sync off of this pathway.
Okay, good. So, Ambien, what I want you to know about Ambien. Ambien is one of the few drugs in our lexicon that the FDA has a gender-specific recommended maximum dose. In 2013, the FDA put out a mandate because of post-marketing data with Ambien. Ambien is a fairly dirty drug. It has a fair bit of side effect for amnesia for nighttime events, impairment in next day function, and so the FDA mandated in 2013 that the maximum dose should be 5 milligrams of immediate release in female patients or 6.25 milligrams of the controlled release version. And I know you're having a type a lot because I got lazy and I didn't put all this stuff inside. Because your fearless leader in the back asked me for the lectures yesterday, and at 9:30 last night I was still laying in bed kind of finishing some stuff up. So that's why you're doing a lot of typing. So other, those are those main ones, yes. Sonata, shorter half-life. Ambien and Lunesta have about a 6 to 8 hour half-life. Lunesta is a little cleaner metabolized drug. Lunesta, an interesting thing about S-Zopiclone is it's one of the few drugs that undergo salivary recirculation. I don't know if you've learned about any drugs up to this point that salivary recirculate, but Lunesta does. So one of the side effects patients may complain of is a metallic taste in their mouth in the morning after taking the drug. Some of them it's so discomforting that they don't want to take the drug anymore. If you have a patient that has the complaint, basically what we do is we have them purge their salivary glands with an acidic juice or a lemon drop or something like that. They can even do it the night before to try to activate the salivary glands, but Lunesta does salivary recirculate. But those are benzodiazepine receptor agonists, so they're working through the benzodiazepine receptor. They're basically on-off drugs. Go activate the benzodiazepine receptor to try to override the brain's activity mechanisms to force it to go to sleep. Orexin receptor antagonist. So I've got a whole lecture on orexin hypocretin after this. So orexin is a peptide complex found in the cerebrospinal fluid and in the brain, and there are two types of orexin receptors. The reason I say orexin hypocretin is because these were discovered at the same time simultaneously in different parts of the world in looking at narcolepsy research. Orexin is deficient in patients who suffer from narcolepsy. We'll go through that in a few minutes. But the orexin receptor, in science, we've figured out that if we can antagonize the orexin receptor, we can put people to sleep. If we agonize it, we can keep them awake. The groundbreaking thing in narcolepsy research was the thought of an orexin receptor agonist. The problem is when I show you a very fancy slide in the next section, orexin deals with every activating center of the brain. And it's this big umbrella with all these fingers. We have yet to figure out how not to screw with every activity area of the brain and only deal with alertness and so forth. And so orexin agonism is not where it needs to be science-wise, but antagonism, this medicine is Belsomra, is the trade name, or Suvorexant. It has been out on the market now about, 3 or 4 years. It's pretty effective, but again, since it works through the dimmer switch model and not the on-off, it's not like your benzodiazepine receptor drugs. Benzodiazepines, there are benzodiazepines that are approved for sleep. Halcyon is one, don't use it please. Restoril is another. that is approved for sleep. They obviously work through the benzodiazepine receptor complex. I'm not a big fan of use of benzodiazepines, especially as sleep aids, but they can be used. Melatonergic system, so you have either over-the-counter melatonin that can be utilized. The problem with over-the-counter melatonin is it's not regulated by the FDA. It's an herbal. So we don't really know the potency from one batch to the next or from one manufacturer to the next. Usually when we use melatonin over the counter, we will start with 3 or 6 milligrams, go up to 9 milligrams. We don't use melatonin supplementation in kids. Why? Has to do with prolactin. Under the age of 18, if you provide melatonin supplementation, you have the risk of increasing prolactin. What are the side effects of increasing prolactin? Gynecomastia, galactorrhea, amenorrhea. Okay? So you're going to work through in Dr. Latassi's section on psychiatric drugs. Well, you did atypicals. So things like Risperdal or Risperidone is very well known to increase prolactin levels and cause a lot of those issues. So melatonin we don't use in kids. So there's a prescription medicine that works through the melatonergic system, and this is Rosarum or Ramelteon. So Rosarum works through that whole pineal, acts like secreted melatonin to interact with the suprachiasmatic nucleus. And the problem with the use of Rosarum or even Suvorexant, Belsomra, is medical providers are now educating their patients because they themselves have not been well educated that how the drugs work physiologically. So patients have an expectation that this is going to be an on-off switch drug instead of a dimmer switch drug. And so patients will come in and complain, well, that didn't work. And it's because they're looking for the on-off switch, the override switch instead of the dimmer switch. And Rosarum, working through that melatonin system, is a dimmer switch drug. Off-label. In medicine, you're going to find stuff used off-label. Trazodone, the old trade name Deseril, is the most commonly used off-label sleep aid in the field of medicine. Why? Cheap. Been around a long time. What should you educate your male patients on if they use Trazodone? Priapism. There was a female nurse practitioner in Oklahoma City that was successfully sued for malpractice in psychiatry for using Trazodone in a patient, whether it was for sleep or not, and not educating them about the risk of priapism. And the male patient suffered irreversible damage and successfully won a lawsuit. So although it is the most widely prescribed off-label sleep aid, I will tell you 9 patients out of 10 have never been told that. So just tuck it in the back of your brain. Other things are used off-label for sleep, other psychiatric medicines. So you've been through atypicals, so you probably talked about quetiapine. What's quetiapine? You got to know generics. Seroquel. So you talked about Seroquel, comes in a long and short-acting form. Seroquel is really not a very good atypical until you get beyond 300 milligrams. Under 300 milligrams of Seroquel, all it is a super expensive antihistamine. So Seroquel is commonly used for sleep. Don't use Seroquel in the jail. They like Seroquel. If you crush it up and put it in the rectum, they get a high. So lots of inmates will ask, especially if they're drug abusers, they'll ask for Seroquel because I can't sleep, and they'll crush it and use it another way. So just tuck that somewhere that you'll never use. Other off-label things, obviously antihistamines are commonly used. Benadryl, over-the-counter. Hydroxyzine, which is Vistaril or Atarax. Prescription medicines that are antihistamines are commonly used to help people sleep. So you can see from an insomnia perspective, there are lots of drugs that are used that can deal with a lot of different conditions because insomnia in and of itself is not just a single entity. It encompasses a lot of different areas. Apnea, this is probably my favorite. obstructive central mixed treatment induced. So let me just walk you through general sleep and apnea physiology. So as we talked about, when we're awake, we have some voluntary control over respiration, and in the nighttime we do not. When our brain sleeps, we march through multiple different stages. So stage 1 sleep is slow, eye-rolling, nodding off sleep. Stage 2 sleep is very light sleep. We've drifted off to sleep, but we can be aroused very easily. Stage 3 and stage 4 sleep have been grouped together over the last several years into what's known as delta wave or slow wave sleep. Why did they name it that? Because if we look at the EEG tracing in somebody who's in delta wave or slow wave sleep, it's a very classical delta electrical pattern. So delta sleep is, slow wave sleep is pretty refreshing, relaxing form of sleep. It's more difficult to become aroused out of that form of sleep. And then we have REM, or rapid eye movement sleep. During REM, we lose muscle tone, so we don't act our dreams out, harm ourselves or harm our spouses in bed at night. But with the loss of that muscle tone, we now have nothing elevating the large neck muscles out of the airway, so we can get collapse or crowding. So apnea itself is defined as a 70% reduction in airflow for at least 10 seconds. That's a single apneic event. 70% reduction in airflow for at least 10 seconds. They're also known as hypopneas or hypoapneas. This is a 30% reduction in airflow for at least 10 seconds, which is accompanied by a 4% change in oxygen saturation. So those two things are very important. So obstructive apnea itself is crowding in the upper airway such that we're reducing the volume of air that flows into the lungs. There is not an intrinsic lung issue. We are still diffusing oxygen and carbon dioxide as we should. We're just narrowing the airway such that we're reducing the flow. And apnea does not have to be a complete cessation of airflow. 70% reduction for at least 10 seconds. So if we have oxygen disruption on a chronic and ongoing basis, there are a multitude of physiological processes that happen. So we have less volume of air, less diffusion happening, so we have less oxygen available. The initial thing that happens, you've been through cardiology, you've been through endocrine? Okay, so you've been through hematology? Sweet. So, low oxygen levels will induce the kidneys to do a couple of things. The kidneys are stimulated to produce erythropoietin, to stimulate bone marrow, to increase red blood cell production. Why? Red blood cells is what are our transport mechanisms for oxygen. We need hemoglobin. So when we spin blood down, one of the components that is measured is hematocrit, and that is the amount of red blood cells in that circulating volume. So initially the brain thinks, I need to increase my transporters, so erythropoietin is stimulated bone marrow to increase red blood cell production. But what happens as my hematocrit rises? My circulatory system is just a pump with a garden hose. Let's dumb it down to that, okay? A pump with a closed garden hose. It's a hydraulic system. And in any hydraulic system, we find homeostasis if that hydraulic fluid is at a certain consistency. So if hematocrit rises, let's use the word, it becomes too thick, okay? So we can't course that hydraulic fluid through there as easily. So the second thing the kidneys are doing is they're telling the whole renal system to filter more. So we're filtering more because we're trying to add a little extra plasma volume so that we can thin things back out so our hydraulic fluid is at a more homeostatic consistency. But what happens? We have a pump with a closed loop of garden hose. Just like your garden hose at home, your arterial system is not real compliant. Okay? It can expand and contract to a certain amount, but not nearly like the venous system can. So what do we do when we add a greater volume into a closed hydraulic system? Pressure volume loop. Our pressure goes up. You have just been described how untreated apneics can develop hypertension. As we are filtering more fluid and adding more volume, though, we may also have some dependent edema because our venous system is a little more compliant and it's going to start storing stuff if I can't pump it all around. So we may have some swelling in the feet or ankles, hands, belly, and we start peeing more. So it's common that patients with untreated apnea will have nocturia. Say, I gotta get up and pee 3 or 4 or 5 times a night. Don't chalk your middle-aged male up when they come in saying, I gotta pee 4 or 5 times at night, to it's the prostate. More commonly, it's untreated apnea. So when I have apneic episodes and I'm trying to breathe in to overcome that, I create a negative pressure in the abdomen. That negative pressure is pushing down on the bladder, so we get the sensation of needing to urinate more frequently, and we already have a larger volume there. We're also pushing up on the stomach. So it's very common that your untreated apneic patients are at greater risk of GERD, nocturnal gastroesophageal reflux, which puts them at greater risk of aspiration. So they have silent reflux, they have their snort, jerk, gasp. And what have we done? We've now aspirated that contents, which are irritants, to the lung. So we're at greater risk of aspiration pneumonia or aspiration-related issues. So with those oxygen changes and things that are going on physiologically, we've got the kidneys activated. We've put a larger volume into our cardiovascular system, so our pressure rises. As oxygen levels drop, there are other brain mechanisms that are activated so that we will increase production of epinephrine and norepinephrine. Why? Well, oxygen levels mirror angst or panic. So if you get scared watching a scary movie, what happens? You start breathing more quickly, your heart races or pounds. Okay? Low oxygen levels do the same thing. Why? Because your body is responding, telling your heart to increase its number of contractions and its force of contractility to get the blood to pump around faster, because it's saying, I've got not enough oxygen, I've got to stimulate this system. Well, your heart is no different than any other muscle in your body. As I work it out inappropriately, it can enlarge, right? So untreated apneic patients are now at greater risk of hypertension, cardiomyopathy. A larger heart functions less efficiently than does a normal size heart, and so we're at greater risk of developing congestive heart failure. Okay? We also know that as oxygen levels drop, we need oxygen to burn sugars, calories, carbohydrates. So our metabolism is directly tied to oxygen. So just like in your fireplace, you need oxygen to burn your log. And how do most fire extinguishers work? Carbon dioxide, they snuff out the oxygen in the area so the flame goes out. Well, your body will rob metabolism of oxygen to keep the other major areas functioning, your brain and your heart. So as oxygen levels stay recurrently low because of apnea, metabolism slows down. We increase our amount of adipose tissue because we got to put it somewhere. Adipose tissue is where insulin resistance begins. Your pancreas starts working harder, and guess what we're now at greater risk of? Development of type 2 diabetes. As blood sugars fluctuate, triglycerides rise. We have an inflammatory response. LDL will rise, and we're now at greater risk of hyperlipidemia. Add into that stroke, heart disease, and heart attack. So if you thought sleep wasn't important when it came to general medical conditions, untreated apneic patients are at greater risk of stroke, heart disease, heart attack, cardiomyopathy, congestive heart failure, hypertension, diabetes, just to name a few. Okay? Those are your obstructive apneic patients. How do we figure out obstructive and then versus the second one, which is central? So when somebody goes in for sleep testing, spouses are good, family members are good, grandpa snores real loud. We watch him stop breathing, in his easy chair. Unfortunately, insurances won't let us use grandkids or spouses or something like that to let us have a diagnosis, so that's where sleep testing is involved, polysomnogram. So when somebody goes in for sleep testing, they're in a laboratory between 8 and 9 o'clock at night, they're done between 5 and 6 o'clock in the morning. We need to know oxygen contents in the blood, efforts to breathe, heart rate and rhythm, muscle movements. We're looking at airflow. One of the things that patients undergo during sleep testing is they have a piezometric or a plasmography belt on, respiratory excursion belt around their chest. Why is this important? Obstructive apnea is an obstruction in the airway with an effort to breathe, an effort to overcome that. How you know the difference in central apnea is you have an apnea with no effort to breathe. So a central apneic event is just what it sounds like. It is a brain-generated phenomenon. So central apnea is generated from the reticular activating system, slowing respiratory effort. So there are several things that can induce central sleep apnea. We've talked about a few of those. Alcohol, opiates, benzodiazepines, congestive heart failure, surgery in the arch of the aorta, stroke in the brainstem. All of those things can put us at greater risk of central changes in our breathing mechanism, and we're at greater risk of central apnea. Patients can't have mixed and central, so they can have obstructive and central components together. How we're figuring this out is that when we're monitoring apneas and hypopneas, when you see an apnea, when you see a 70% reduction in airflow, the first thing you do is you pair it with piezometric respiratory excursion effort. If there's no respiratory excursion effort in that piezometric belt, you're dealing with the central apnea. And so you can see whenever we're scoring sleep studies, if they're having obstructive versus central events, and some patients don't have only obstructives or only central events, they may have mixed events, they may have obstructive and central events. Now, it's very common for the healthy person to have sleep onset central apnea. You or I, every night when we go to sleep, when we first drift off, you're having a physiological state change to where you're coming out of the ability to somewhat be in voluntary control of your respiratory drive to your brain completely taking over. And because of that, we can have momentary cessations in breathing that are actually defined as sleep onset central apnea. That is not an abnormality. It is normal in just about anybody that first drifts on off to sleep. Now, we can also have treatment-induced central sleep apnea. So we're going to talk about how we treat apnea. But by treating somebody's obstructive sleep apnea, I can actually confuse the brain. And so we can actually induce what's known as treatment-onset central apnea in patients that we're treating their obstructive sleep apnea. And these become more complicated. Sometimes they call them complex apneics, but they are treated in a little different way. So before we move from apnea, because apnea is very important. Any questions? Actually my favorite, but no questions? You all got apnea perfect? Good, because I wrote lots of questions on it for your national exam. So how do we test? Polysomnogram? Yes?
Sorry, I just wanted to confirm obstructive versus central
Yes.
apnea.
Okay?
Central is from the brain without effort
Yes.
to breathe in, and obstructive is trachea collapsing and then effort.
Yeah. Those are the easy ways to think about it. So, yes?
I have a really quick question. So I'm trying to connect CHF with central apnea,
Okay.
and I'm not quite making the connection. Can you explain that a little bit further?
So we know that in patients with central apnea, in patients with congestive heart failure, their chemoreceptors function differently. And because of that, they are sending inappropriate or incorrect signals to the reticular activating system because of that cardiomyopathy. And that's why they have central apnea. Okay? So polysomnogram is what I described, going in between 8 and 9 o'clock at night, being done between 5 and 6 o'clock in the morning. You're wired up like a little bit like the Bride of Frankenstein. We need to have a EEG montage. We need to know about efforts to breathe, muscle movements, oxygen content in the blood. Second part of sleep testing is if somebody is diagnosed with apnea. The treatment phase of that is what's known as positive airway pressure titration. This is where we basically provide sealing of the nasal and oral airway with an interface. I hate the word mask. Use an interface to deliver positive airway pressure to pneumatically splint the airway open. We are not using a ventilator in this particular situation. All we're doing is splinting the airway so somebody can breathe as they've been designed to breathe. So during the night of a positive airway pressure titration, patients are typically started at a pressure of 4 centimeters of water pressure, and they're slowly titrated up until we have resolution of the apneas and oxygen that's maintained above 90%. Now, the definition of apnea severity: less than 5 apneas an hour is normal in adults, caveat in adults. Between 5 and 15 events in an hour is mild, between 15 and 30 an hour is moderate, and greater than 30 an hour is severe. So a successful titration does not have to be complete resolution of apneas, it has to be 5 or below, is what we shoot for, because some people are really difficult. In children, apnea is defined as 1 breathing event per hour. Adults, greater than 5. We have a mild, moderate, or severe not because they're at greater risk of different things in the severity level. It's for insurance. Insurance is like gold, silver, bronze, first, second, third, mild, moderate, severe. Mild apneics are at the same risk as moderate and severe apneics are for the development of all of those big, bad, and ugly conditions that I just mentioned. Now, one thing I mentioned in insomnia is sleep maintenance insomnia can commonly be associated with apnea. Why? What's the physiological mechanism? I kind of already mentioned it, but low oxygen level causes release of which neurochemicals? Epinephrine, norepinephrine, which are activating chemicals. So if you're in a scary movie and you get scared when the chainsaw guy jumps out from behind a barn, are you going to be able to go to sleep like right after that? Your heart's racing and pounding and your throat's dry, and no, you've been activated. Well, when somebody has low oxygen level and we induce those because of apnea, the brain is going to arouse us. Why? So we can regain muscle tone, so we can pull the muscles up out of the airway, so we can be exchanging oxygen and carbon dioxide at a normal volume. What do you think the brain is going to want us to just go right back to sleep and do that again? No, we've been aroused, and we will be aroused multiple times through the night if apnea is untreated because of that mechanism. Split night just basically is, there's no code for that. So if you were having to code a PSG, it's a 95-810. A PAP titration is 95-811. You don't have to know that. A split night, there's no such code for that. It actually started as a convenience to medical practitioners, in that we would try to do the diagnosis and treatment all in the same night. So the Academy of Sleep Medicine, the Association of Professional Sleep Societies, the International Classification of Sleep Disorders said, we feel like it's okay that if you find apnea within the first 2 hours, you can wake patients up, spend the rest of the night titrating their positive airway pressure device. That's called a split night study, and we bill it as a 95-811, which is a titration. Insurances like it because they get off with only paying for 1 study instead of 2. However, sometimes it's difficult to diagnose and treat all in the same night, but that's split night. Multiple sleep latency testing is something that's not done in apnea. That's done for narcolepsy patients. So if somebody is being evaluated for excessive sleepiness syndrome, we will do a nighttime polysomnogram, and it has to be normal, meaning no apnea. Then they have followed up the next day what's called a multiple sleep latency testing. And this is where they have 5 scheduled naps through the day. And we're looking at how quickly do they go to sleep and how quickly does their brain get into rapid eye movement sleep. Because the diagnostic criteria for narcolepsy is a very short sleep latency and at least 2 bouts of sleep onset rapid eye movement in those naps. So multiple sleep latency testing, what you really need to know is that's the test that we use for narcolepsy. You probably won't ever be ordering those unless you work in sleep, and as a sleep specialist, we would evaluate to decide if that's necessary. Maintenance of wakefulness testing, this is actually to see if somebody can maintain wakefulness, mainly for if they're treated for their apnea. Department of Transportation, pilots. Those are the 2 main groups that we do maintenance of wakefulness testing. It's the opposite of MSLT where they're told get in bed and try to go to sleep. Maintenance of wakefulness testing is hey Jack, don't go to sleep. But you can't do repetitive motions and other things like biting your lip and so forth to try to stay awake. They're just put in a dark, semi-dark room that's very boring with no other external stimuli, and we measure how long it takes them to go to sleep so that we can prove that either they're adequately treated for their sleep condition so that they can be safe to either drive their big truck or fly. So I can guarantee you, you won't ever be, unless you work for DOT physicals, but then they're still sent to sleep specialty. But maintenance of wakefulness testing is really the opposite of MSLT, but it's looking to see is somebody adequately treated. So I mentioned positive airway pressure therapy. As in medicine, always, there's not just one kind. There are multiple different types. So it's broken up into CPAP, bilevel, ASV, AutoPAP, and non-invasive ventilation. CPAP is continuous positive airway pressure device. This is one pressure all the time, whether you're inhaling or exhaling. Bilevel is when you breathe in, you have an inspiratory pressure, and when you breathe out, the machine is designed to reduce the pressure by up to 4 centimeters of water pressure to make it easier to exhale. Adaptive servo ventilation is complicated, we'll go through that in a second. AutoPAP is basically CPAP with a brain. So CPAP, we set the pressure, one setting, all the time to splint the airway open. AutoPAP is we give the machine a pressure range, and the machine is using a mathematical algorithm to calculate airway resistance to decide what pressure to provide, but it's at a continuous pressure. When a patient exhales, we don't drop in expiratory pressure. There's no EPAP. IPAP and EPAP, have you been through pulmonary yet? IPAP and EPAP are the same. Bilevel, IPAP and EPAP are different by 4 centimeters of water. So AutoPAP, we give it a pressure range, and then we allow that machine to adjust, because some patients need a larger pressure on their back, because we're most dependent against gravity. On our side, we get to use gravity a little bit to our advantage, and so somebody on their side may not need as much of an inhalation pressure, so depending on how they're sleeping, that may change, and will allow the machine to do that. Insurance now pays the same price for AutoPAP as it does for CPAP, so we put autos out on everybody, just so that we can use the technology. Adaptive servo ventilation. This is a very complicated device. Unless you work in sleep medicine, you will never deal with these. We deal with them all the time. This is the treatment for central sleep apnea. The reason being is that these devices memorize the breathing pattern of the individual, and they recalculate every 3 milliseconds as to what's going on with the patient. Because these patients may not only have crowding in their airway, but they may not have the effort to breathe. So the machine is actually injecting pressure to tell the system when to breathe, as well as splinting the airway open. So these machines have fluctuating IPAPs and EPAPs and end expiratory relief pressures, and they're just really, really complicated. What you just need to know is that adaptive servo ventilation is really used to treat central or mixed apnea patients. To use this type of machine, they have to have at least a 50% central apnea rate. So we don't use them on patients unless they have at least 50% of their apneas are central. There's also some data that shows utilizing central or ASV in congestive heart failure patients increase their morbidity and mortality. So there's a lot of debate and a lot of research going on right now. If it's known that the central apnea is what is inducing the central sleep apnea, if it's known that the congestive heart failure is inducing the central sleep apnea, the recommendation at this point is not to use adaptive serval ventilation. If it's a patient that has congestive heart failure, but they have treatment onset central apnea or apnea that's induced by opiates or something of that nature, we can use adaptive serval ventilation and not increase their risk of morbidity and mortality. But you just need to know that's central apnea. We can induce central apnea by CPAP. So if I inject pressure in somebody at a constant rate, sometimes the brain gets a little confused and says, well, Jack, I'm getting a little more than what I need, I'm going to slow my respiratory effort down. So it's not uncommon that somebody who first goes on CPAP, we can see them have centrally induced events. Most of these patients, their brain settles down on treatment and we don't have to go to something like adaptive serval ventilation, but we can get treatment onset central apneas. My beef with bilevel positive airway pressure, I am not a fan of bilevel, and here's why. If patient X requires 15 centimeters of water pressure to splint their airway open because of apnea, most not astute medical practitioners that are writing for bilevel will say, well, Ms. Jones says it's hard to breathe out against that pressure, so I'm going to put her on a 15/11 bilevel pressure. So her inspiratory pressure is 15, her expiratory pressure is 11. What have I done to her airway? If 11 centimeters was appropriate enough to splint her airway, would I have not set her CPAP or her inspiratory pressure at 11? No. I'm allowing her to collapse her airway every time she exhales. So if you use bilevel appropriately, and somebody, Ms. Jones, says, well, I can't breathe out against the pressure, it's too high. If you were to use bilevel, you'd actually need to be on 19/15 because your end expiratory pressure would be what was necessary to splint the airway open, if that makes sense. Now she's really going to hate you because she can't breathe in or out against the pressure because it's too high. So I'm not a big fan of bilevel because it's used inappropriately so often. And bilevel is much more commonly seen to induce persisting treatment-related central apneas. It will make them worse. So I just am not a big fan of bilevel. So to be a good, astute medical practitioner, you have to give people options. CPAP is the gold standard. Positive airway pressure device is the gold standard in all of treatment of apnea. However, there are some patients that want to do the last one here, and that's refuse. They want to accept all the risks associated with untreated apnea, and I document out the yin-yang in those charts. It's their responsibility. I've given them all the options. There are other options. UPPP, uvulopalatopharyngeoplasty. Have you had ENT yet? Okay, UPPP, removing tonsils and adenoids, the uvular part of the soft palate, in an attempt to open up the airway. ENTs like to do it. It is not going to be curative in 99.5% of patients. Less than 0.5% of patients have resolution of symptoms with UPPP. It can be used to help reduce positive airway pressure device pressures, but it's not going to be curative in the far majority of patients. Plus, it's a miserable surgery in adults. Now, in children, tonsillectomy, adenoidectomy is a treatment of choice in apnea. Kids, AHI, have apnea hypopnea index greater than 1, treatment of choice is tonsillectomy, adenoidectomy. I did it to my own daughter. So, the other option is mandibular advancement device. Made by a specialty dentist. It's a device that's worn in the mouth to help pull the lower jaw forward and keep the tongue pulled forward out of the airway. The dentists want to convince patients to use these things. I hate them. Again, less than 0.5% chance that you're going to correct the airway. You've got to crank the lower jaw forward so far that you put so much pressure and strain on the temporomandibular joint that you've now created another problem. Guess what also? Medical insurance won't pay dentists to do work, and dental insurance won't pay for medical devices, so mandibular advancement devices are cash business. Dentists love them.